Hi, Dr. Brian Kaufman, a retired family doctor and a CLL patient myself, the co-founder, chief medical officer, and executive vice president of the nonprofit CLL Society here at ASH 2022 in New Orleans.
Hi, I'm Talha Munir. I'm a hematology consultant working at St. James's Hospital in Leeds, UK. It's an absolute privilege to be here in New Orleans, and I'm delighted to be here and presenting some of the exciting data, as well as looking at the absolutely great amount of research that's happening in the world of CLL.
Dr. Munir, you and your team out of Leeds has led some incredible research in CLL. I would say practice-changing research. And I'm going to read one of the papers that you made an oral presentation on, which was this Clarity study, which has been looked at all different kinds of ways because it's got so much great data inside it. And it was MRD4, which means measurable or minimal residual disease down to 1 in 10,000 cells, eradication, so this would be less than that, eradication at 6 months and early clearance of MRD with a combination of Ibrutinib plus Venetoclax results in sustained clinical and MRD response, exploratory analysis of blood cancer, UK TAP Clarity study. That's a lot. Can you kind of unpack that for us so patients can understand what this study was about, or at least this part of the study was about, and why it might be important to patients?
Yep, I'll try my best to clear that up, but the name of the study was Clarity, which was the first study in relapsed refractory CLL patients, which means that patients' disease have relapsed. And in those patients, we combined Ibrutinib and Venetoclax together. And the main focus of this trial was to design the therapy based on the response that the patients were achieving with individual therapy. So just to give you an example, that if the patients had Ibrutinib and Venetoclax for 8 months, and we did this test called minimal residual disease in the blood and in the bone marrow, and if they were found to be negative, then we thought that actually the disease response is excellent, and the patients will get 6 more months of therapy, and then they would stop treatment at that point. Now, another patient may have a response at a combination of 14 months, and in those patients we gave them 12 more months of therapy and then stopped therapy. So the whole point of that was that this was individualizing therapy based on the response from individual patient, because what the thought process was that not every CLL is the same and every patient's disease behaves in a different way. So in this study now, we have got a longer 5-year follow-up, and we were able to share the data with our colleagues and with the whole ASH meeting.
Dr. Munir, I think some of this was mathematical modeling that your team did, and they said, well, if somebody goes down quickly over 6 months and they get to where we can't detect the disease down to the level of 1 in 10,000 cells, another 6 months will drive it even further at that same rate. But if somebody takes a year to get there, then maybe they need another year because the disease is being eradicated at a slower level, so they need more of a push down. Is that a correct understanding?
That's the correct understanding, and we did quite a lot of minimal residual disease monitoring, and one of the other things we picked out that there were a group of patients, nearly half of the patients, who were exquisitely sensitive to this combination. So nearly 25 patients had what we call as 2 log reduction in MRD in the first 2 months of combination. So that 2 months of combination led to a very, very deep response very early on. And what we found that 19 out of those 25 patients continued to have a very good response later on. So that early response was able to tell us which patients are going to do the best and the other patients who might need longer therapy as well.
So these are 2 very powerful drugs. And they do have side effects. I'm sure you looked at those safety and side effects issues. Can you share that?
Yes, in terms of the safety, we had 50 patients enrolled onto the study, but 4 of the patients initially dropped out. So we actually had 54 patients because they got some toxicity initially, which was some of it was infection, and another patient got a heart problem, but they already had a heart problem before. But overall, once we've looked at the 5-year follow-up data, we're not seeing any new safety signals. It is pretty much the same what we saw before. We had 3 patients who got COVID-19 in the study despite having vaccinations, and actually all the patients recovered very nicely. So it means that this combination is not affecting the immune system too much, and patients were able to recover from the infections as we would normally see in CLL patients.
Did any patients die during the trial?
One patient, well, there are a few deaths which have happened, and they have happened later on. There were some progressions as well, which led to deaths of the patient. So 3 patients died to this horrid complication called Richter's transformation, which we do see in relapsed refractory CLL. Some patients had died because of old age, actually with Alzheimer's dementia as well. So we had a few of those. And then there are 3 CLL progressions, which eventually led to, unfortunately, demise of the patients. So yes, there were some deaths, but there were no toxicity-related deaths that we saw in the trial.
So you've already kind of given us a hint of the responses, if we, what I'm hearing, but tell us a little bit about what the response rates were like, what the progression-free survival, overall survival was for this powerful combination.
So that's the exciting bit of the study. Although the study is a phase 2 small study with 50 patients, but we found that we still haven't seen progression in half of the patients at 5 years. So the estimated progression-free survival at 5 years is 78%, which means 3 out of 4 patients are still disease-free, which is very good to know. And then 9 out of 10 patients are still alive. And we had some deaths which happened in the 6th year, which were mostly unrelated to CLL.
Well, these are incredible numbers, and this is a very exciting combination. Any kind of conclusions you want to draw from this? I mean, patients must be excited about this, but are there any caveats, any concerns you have, or are you just give us a sense where you see this fitting in?
So I think where I see it fitting in is exactly where the data from Murano study places itself, with combination of Venetoclax with rituximab in the relapsed refractory space. Unfortunately, the problem is that all of these combinations which we initially started in the relapsed refractory space have moved on to the frontline space. And as a result of that, there is a lack of phase 3 data, which leads to approval of these drugs. These combinations is lacking in this space at the moment, but hopefully we will accumulate that data, especially then because a lot of our CLL patients are now getting treatments with targeted drugs when they are presenting initially, whereas this study, when it was designed, chemoimmunotherapy was still the standard of treatment in the frontline space.
Any final thoughts you want to share with patients about this research?
I think this was one of the first studies to look at this combination. What we were able to share here is the long-term data now. What we saw with the early time points with this concept of minimal residual disease, that ties up very nicely with the longer term follow-up as well, with the progression-free survival. So all in all, I think it tells us that this is a potent combination in the relapsed refractory space. And I was very privileged to share this data on behalf of my co-authors and team from UK.
Dr. Munir, I've always been impressed with what your group, with yourself and Dr. Hillman and Dr. Ralston, and have just done some incredible research. Thank you so much.
Thank you.